Evening, everyone. Can everyone hear me now? Okay, yes. We're sorted. Sorry for the technical troubles. I'm Dr. Eve Bailey. I'm one of the GP liaisons working for the Department for Health and Wellbeing, and welcome to our second webinar in our series of 2 on long COVID. And tonight is a joint presentation by SA Health, Department for Health and Wellbeing, CALHN and Adelaide PHN. So thank you for everyone's efforts to be here tonight. We have, first of all, 2 very experienced presenters to welcome, and following their presentation, I'll be doing a short presentation from GP perspective on long COVID as well. So if you have time, please stick around for that. So to introduce, we've got Professor Dennis Lau. So Professor Dennis Lau is a cardiologist and electrophysiologist with a great interest in dysautonomia and POTS, and he'll be joined by Marie-Claire Seeley, who's a very experienced clinical nurse consultant working alongside Professor Lau, working on her PhD, and also the founder of the Australian POTS Foundation. So welcome. I'm going to hand over to Dr. Dennis Lau now and take it from there.
Thank you, thanks Eve, and thanks for having us, thanks Claire and myself. So I'll get started with the presentation, and then halfway through or towards the end of mine, I'll get Claire to take you guys through sort of autonomic assessment in patients who you suspect may have long COVID. So I need to learn to share my screen. So let's see. Here we go. Okay, can you guys see my slides? Good?
Yep, that's great. Yeah, that's perfect.
Okay, perfect. Thanks. So look, we're going to talk about this autonomia and long COVID, and we just sort of take you through this. Now, most of us are familiar with the WHO definition of long COVID, and that is people who are still symptomatic at least 12 weeks after the acute COVID-19 infection. There's also another term that's been used a lot, PASC, so post-acute sequelae of SARS-CoV-2 infection. So we have read in the literature, especially from overseas, because our COVID sort of wave is a bit behind that as compared to overseas, and you can see that the early reports show that patients have a constellation of symptoms, including fatigue, shortness of breath, cough, headache, loss of taste and smell, cognitive and mental health impairments were reported, and those were the things that you may see in a lot of patients with long COVID. So the estimation currently is that approximately up to 20% of people will have some mid to long-term effects after they recover from the initial COVID-19 infection. So here are a couple of papers that came out even last year, where people describe potential autonomic dysfunction in patients with long COVID, and I won't go through the details. Suffice to say that there's increasing reports these days, with some even giving us a bit of prevalence of this. Now, obviously, there are still sort of large-scale data that we do not have, but I think we had a early report from Sydney, New South Wales, showing also a high percentage of this in their preliminary data, but the paper has not been published. So this is a series from overseas. It's a small number, but why am I showing it is because this is a paper where they actually perform autonomic testing. A lot of other series that are reported are based on questionnaires where people suspect potential autonomic dysfunction. But in this paper, 17 out of 27 individuals with long COVID actually had abnormal autonomic testing results. So 41% actually had orthostatic intolerance with either low blood pressure or tachycardia, and 1 in 5 fulfill the criteria for POTS, and 11 borderline for OI. Most patients that they saw in this series had mild symptoms, but obviously this can vary significantly. So what are we dealing with in Australia? I looked up the numbers on the weekend. We have more than 10.5 million cases of COVID-19, and I'm sure this is under-reporting, with lots of people now not even getting tested and lots of people not reporting their infection. And if we even use just 5%, not the whole 10 to 20% of the WHO estimates, that will give us 500,000 of people may be suffering from long COVID. And if we were to be conservative, just 30 to 50% will have a degree of dysautonomia from this 500,000 of people with long COVID, then that will give us about 200,000 patients in this country with potential dysautonomia after their COVID infection. So these numbers will continue to rise as we still getting new waves and new variants of COVID. And we are dealing with essentially a difficult condition. It is quite complex, and there are long waiting time in the public clinics. So what my personal experience with people coming to see me is that we have found, Claire and I, that there are certain lack of expertise in how we manage this, purely because we were not taught about dysautonomia in medical school or in nursing school. And this is a new disease that we need to learn how to diagnose and how to treat. And therefore, we are here tonight and hopefully can help you to manage some of your patients. Before I go on to talk a little bit about the management and diagnosis, I would like to show you some of the data. So Claire, this is all Claire's PhD work. One of the main projects is to look at the dysautonomia in long COVID patients. She started this project in 2020 when we were in kind of a lockdown, and we had to send her to Melbourne to see some long COVID patients initially. Thankfully or not thankfully, we have cases in South Australia, and there's a lot to follow up here. So this is from our experience of just 54 patients where we've done detailed testing and patients who have provided consent for this study. There are others that we could not include as a result, including those who are under 18 years old. So the mean age of the people that we have seen is 38.5, and 80% are female, and majority are Caucasians. Almost 70% already had COVID vaccination prior to their infection. Of note, a third of these people who have presented to our EDs with symptoms and often get sent home. Only one managed to get admitted for inpatient care. And the onset of the orthostatic intolerance symptoms are at a mean of 12 days after the COVID infection. So they may not develop those symptoms right acutely, but often it could be up to a few months after the COVID infection. So the mean duration of their symptoms at the time of us doing the autonomic assessment was about 9 months after the COVID infection. And notably, a lot of these people were unable to perform their usual work, with 15 days on average where people could not go to work before the appointment with us. Now, this is the table showing just the constellation of symptoms that you would expect in this patient. And if you were to look at those highlighted in green, these are people who had acute infection on the middle column, and on the right, chronic, meaning first acutely at the time of COVID infection, and chronic is at the time that they came to see us, and the average of 9 months from their infection. You can see that the percentage, for example, for shortness of breath continue to increase from initial to 9 months afterwards. There's also increase in palpitations, tachycardia almost double, as well as dizziness. And a lot of these patients also get a constellation of GI symptoms, including abdominal pain and also urinary symptoms. And last but not least, a lot of them were unable to focus or concentrate, what we know as brain fog. So this is the autonomic testing that we undertook in this 54 PASC patient, and we compare that to 35 patients that we see in our clinic with POTS, and then 31 were healthy volunteers that were aged and gender matched. What you will see here is obviously on the standing test, the people with POTS will have fulfilled the diagnostic criteria, which is a 30 beat or more increase in the standing heart rate for up to 10 minutes into the standing test. without any drop in their systolic blood pressure. And what you can see here is this is the long COVID patients. 3/4 of them will have similar tachycardia that will fulfill the diagnosis of POTS. And a lot of them were still very close to the positive criteria, that is between 25 to 29 beats, and less than 20% were negative for the diagnosis of POTS, and versus controls 100% were negative. So this is just to illustrate that they are quite similar to our usual patients with POTS on the standing test. Now, the COMPASS 31 is the tool that is used commonly to look at autonomic symptoms, and this is the overall score. For those of you who are not familiar, those who you consider to have moderate to severe autonomic dysfunction, if your score is 41 or above. Okay, so what we see here is overall, and the POTS cohort have a total score of 53, control of 10, and the long COVID of 51. And these were all statistically significant. And patients would also specifically looking at orthostatic intolerance, a component of the COMPASS 31 score. You can see that it's quite similar in those with long COVID versus those with POTS. So when we look at the change in heart rate, you can also see that this is significant with the long COVID individual showing a 42 delta heart rate increase from lying to standing as compared to POTS. Patients of 48 and control of 16. Now, these were just what we analyzed earlier, so we could have updated this, but we didn't have time for today's presentation. And when we look at the individual component of the COMPASS 31 score, you will see that high proportion orthostatic intolerance and all the other autonomic from GIT, bladder, pupillary motor, secretory motor, and vasomotor were also higher in the long COVID, not far from the POTS percentage as compared to control patients. So how is this affecting the individuals with long COVID? Now, this is there are two different scores on here. On the left here is a scale for a visual analog scale from the EQ5D questionnaires for the quality of life. And you can see that the higher the score is, this is how they feel the quality of life is on the day that they feel in the questionnaire. The healthy controls had 85 out of 100, and then the POTS and PASS patients were around the 40% only. We then translate the EQ5D 5L questionnaires to also look at mean utility score. This is something that the health economists use a lot, where they compare this to a standardized normal population of people. In this utility score on the right, the scale, 0 is people saying that their quality of life is equate to death. There's no point living, versus 1 is full health. So the healthy controls reported score of 0.94, which is to be expected. And you can see that in the POTS and the long COVID patients is significantly lower at around 0.6 only. Now, what is this in terms of relevance to other chronic disease? So this is a different study that we did of patients with POTS, so also showing score of around 0.6. You'll see that using the same EQ5D health utility score assessment, for example, people with diabetes will still report a utility score of 0.83. Cardiovascular disease, COPD, cancer, chronic kidney disease, they're all higher, telling us that patients with POTS and long COVID are really not having a good time. So I'd like to turn your attention to now just going through zooming into POTS. Now, POTS is a form of dysautonomia, and this is what I've alluded to earlier. If we just do a standing test, you don't need to send a patient for a table test to get this diagnosis. In adults, exaggerated heart rate increase more than 30 beats per minute is sufficient to provide a diagnosis. That's a word of caution. Sometimes patients do not show any increase up to 30. It could be 20. or sometimes the baseline heart rate is over 100. But if they stay above 100 throughout the whole duration of 10 minutes, that is still considered positive. So also patients with POTS may or may not have a positive standing test every time you do it. So a negative test doesn't exclude it, and Claire will go through with you other assessments later to help you when you are suspicious that someone may have POTS. You still repeat this on a separate occasion, and ideally this should be done in the morning rather than the second half of the day. So importantly, the definition for POTS is that there must be an absence of orthostatic hypotension, so there must not be a drop of more than 20 or 10 in diastolic blood pressure within the first few minutes of standing. So what is important also is we won't call someone having this diagnosis if they have not been unwell with symptoms of orthostatic intolerance for at least 3 to 6 months. And this often, the common symptoms will be lightheadedness, blurred vision, cognitive difficulties, and weakness, in addition to the tachycardia, that they can't just stand for a long time. Now, this is a no-brainer that we need to make sure there's no organic disease that will be accountable for the sinus tachycardia. Check their thyroid, make sure they're not on medications that will contribute to tachycardia, and also things like anemia. So a reminder here really that when we talk about autonomic dysfunction, the nervous system controls a lot of vital bodily functions that we don't think about day to day. Obviously, when we talk about POTS, there's the heart rate control, blood pressure control going out of the window. But you know, the autonomic also controls your temperature, your bowel motility, your breathing, your sweating, and your genital urinary function. So there's the parasympathetic and sympathetic, how each organs can be affected. So these are patients who often present with a constellation of symptoms, and sometimes just localized to 1 or 2 systems, but this may also evolve over time. They may show up with lots of temperature dysregulation, for example, with tachycardia, and a few months later, it could be something else. It could be the gut not functioning, lots of bloating, nausea, early satiety that will be involving the gut motility. So just watch out for a lot of different symptoms. Now, when we look at POTS normally, this is not in consideration of the long COVID, because in the long COVID population, there's still the same predominance in female patient, but the onset now, because of the post-viral situation, we do see people older in age, post-COVID with long COVID with POTS, but the usual description is from teenage years onwards when they start to present with this. Now, there are a set of triggers, so you can see their infection. So that's where COVID-19 will fit in, but other scenarios will be post-surgery, pregnancy, concussion injury, or some patients with gradual onset, and those are more likely patients who actually have hypermobile syndrome, joint hypermobility, where the onset of POTS may be more gradual as compared to the post-infective or trauma onset. So the symptoms are vast, and these are the ones that you could link to poor perfusion. Perhaps the blood's not getting to the brain, people get visual disturbances, dizziness, and also sometimes they could faint. And also sometimes you can also have symptoms due to increased sympathetic, when they get the palpitations or the tachycardia, the clamminess, the difficulty falling asleep. And there's a lot of other symptoms. Chest pain we see all the time, headache, shortness of breath. And no matter what test that you do, it's very unlikely you pick up any other pathology. So this is just a brief schematic to show you the complexity of this condition, where there are multiple etiology or theories that could explain from immune-related, where there's a component of mast cell activation syndrome. Autoimmune conditions are sometimes often seen in this group of patients. It could be neuropathic, hypovolemic, hypoadrenergic, or simply related to joint hypermobility. So in the patients that we look after, we will try to we don't always give them a classification, but this is always at the back of our mind, because knowing what sort of predominant features they are will help us to choose which therapy we will commence them on first. Now, this is just a basic, again, schematic looking at the standing test. So this is supine, lying down for 5 minutes and standing a patient for 10 minutes. And in this example on the left, it is really showing minimum change in heart rate. So this is on the tilt or standing test. When you stand them up, there's no change in blood pressure in the normal control and marginal change in heart rate, if any, over the whole duration. In the POTS patient, you can see a significant rise that often happens within the first few minutes, and then that remains elevated for the whole duration of the test. As soon as they lie back down, the tachycardia resolves almost immediately. And as I mentioned before, the tests are more likely to be positive in the morning than in the afternoon. So if you get a negative test in the afternoon, feel free to repeat it on another day, and you might find a positive result. This slide is to remind all of us that the tube table is not necessary. It's a long waiting time in the public for this, and I'm not sure it is actually adding much to the diagnosis. So a standing test, as shown here in the round dots and in the squares, are the tube table tests. So let's look at the control in the blue. You can see that in the control patients, you do a standing test. This is what happens to the heart rate. On average, never will go through the 30 beats per minute mark. But if you start to put even normal patient on it, sometimes you can cross the line. So essentially it's telling us that the tube table exaggerates the findings and may not be as sensitive as compared to a standing test. Likewise, with the stand test in the POTS patients, you already crossed the 30 mark, but a tube test will exacerbate it. So that's just a reminder. The utility of just standing test alone is sufficient. Now, we did a meta-analysis and systematic review a few years ago on POTS treatment, and we found that the data available for this is quite abysmal, with a very low number of patients actually being studied in the randomized control manners. It's being increased a little bit, but I don't believe it's more than 200 yet up until now. That was 4 years ago. And none of the treatments really show high efficacy by including fluids, fluorocortisone, drinking salt and water, using vasopressors like midodrine, heart rate reduction like beta blockers and ivabradine. All of them are between 60 to 70% efficacy in improving POTS symptoms. And also exercise training appears to be useful at similarly around the 70% mark. But there's likely overestimation, as patients who dropped out were not calculated, and the different ways that they use to gauge response. So that was a number of years ago, reminding us that it's not easy to treat this group of patients. Next, I'm going to pass on to Claire to talk about the nursing and multidisciplinary assessment that we undertake here to help look after the patients. So off to you, Claire.
Thank you, Dennis. So because of the vast amount of systems that are affected by the autonomic nervous system, obviously these patients need a pretty substantial systems assessment, and so we use the nursing clinic for that, and that encompasses a full system health history, plus we use screening tools, which I'll go through in a minute, as well as some autonomic function testing equipment. But a lot of this could be carried out in a GP clinic, understanding, of course, that you have a lot less time than we do, and you might need to utilise some of your chronic healthcare plan and GP management plan time. And if you have the luxury of a practice nurse, that might be helpful for you. So I'm going to go through the assessment tools, and then I'll do a quick case study for you. So we use predominantly the Compass 31, which is the Composite Autonomic Symptom Score Index. There is a new tool that's just been developed for POTS, but it is relatively new and we haven't really established how helpful that is yet, but it's called the Malmo tool. We also look a lot at gastric dysmotility, because the autonomic nervous system really affects that area in our patients, and so the gastroparesis cardinal index score is very helpful for that. The fatigue severity score, that gives us some indicator of whether the patient is ready and appropriate for graded exercise therapy. And we also look a lot at hypermobility because this tends to affect outcomes in patients. And particularly we look at the 2017 hypermobile Ehlers-Danlos syndrome tool. So just running you through COMPASS, this actual schema came from a recent study that was done on PASC, and they use the COMPASS score. A lot of the literature out there at the moment actually are cross-sectional studies using the COMPASS index. The COMPASS index was really developed for autonomic dysfunction in diabetic patients. It does work for POTS because it's another autonomic disorder, but there's no clear cutoff for defining who has POTS with the COMPASS. You just need to know that the score is out of 100. The higher the score, the more significant the autonomic dysfunction. Different groups use different cutoffs. We tend to look at anybody with a cutoff around about 20 is a good indicator that they might have POTS. And obviously, if it's a lot higher than that, then we see, we consider that they probably do have it. It looks at orthostatic intolerance at the top there. Then it also looks at the vasomotor reflex, the secretory motor, the bladder, the GIT, the bladder, and the pupillary motor reflexes. So we also use the GCSI. So this is just a scale that looks at these different domains that you can see there on a scale, a Likert scale of 0 to 5. A score equal to or greater than 2 on this tool would indicate that the patient actually might have gastroparesis. It's a little bit deceptive in POTS patients. Autonomic dysfunction of the small bowel results in both dumping of food from the pyloric sphincter as well as gastroparesis. And patients can actually fluctuate between those two conditions. Likewise, they have difficulty with pancreatic enzyme release. They also have glucose insulin issues, imbalances, and they can have problems with their gallbladder, which is also innervated by the autonomic nervous system. So you can imagine there's a plethora of different symptoms that may come out through the gastric symptomology. So briefly, this is probably a bit complicated to undertake in a 10-minute GP appointment, but just so you're aware of the hypermobile spectrum disorders, which have a close association with autonomic dysfunction. Primarily, we think because of the connective tissue involvement with the nervous system. So there are 13 subtypes of the Ehlers-Danlos syndrome, but the one that is most closely associated with autonomic dysfunction is the hypermobile type. There is no gene mutation noted for this type, so it's determined on a clinical diagnostic tool which we use, and that has 3 criterions that you need to look at. This is readily available, this tool, and I'll show you in a second a bit about it. People with hypermobile EDS tend to have associated conditions of lots of neurodiversity, such as ADHD and ASD are very common, endometriosis, Chiari malformations, sleep-based disorders, celiac disease is very common, well, more common than the general public, and they tend to have problems with joint dislocation or unstable TMJ or SIJs. They also have a bleeding diathesis that is not able to be picked up on clotting. So it has to do with the interface of the collagen and the platelet disorders. And so they tend to have mucosal bleeding incidents. As I said before, a high incidence of ADHD, and it's important to know about 30% of POTS patients have hypermobile EDS. And a lot of patients, about 50% of those with EDS have POTS. In our PASC population here, 25% have hypermobile EDS and another 33% fit onto what we call the hypermobile spectrum disorder. So it's a large amount of our cohort. So very quickly, that's the type we're looking at, the only type of the Ehlers-Danlos syndromes that has no genetic code. And this is the tool that is used to assess it. So we look at the Bateman score, which is about the hypermobility of the upper and lower limbs, and as well as the ability to touch palms to the ground. A score generally for an adult of 5 or greater is positive. And then we also look at mild hyperextensibility of the skin. Anything more than that would be considered a marker for one of the other types of the Ehlers-Danlos syndrome. The stretch marks across the back are a high indicator of this condition. Unusual stretch marks. This is one of the armpit of one of our patients. Certainly not a place you would expect to see a stretch mark. Atrophic scarring, those pysogenic papules, some of the arachnodactylity signs similar to Marfan's will be found in these patients as well. Okay, so I'm going to take you through a case study just to give you an indicator of one of our POTS patients that has PASC. So this is a 28-year-old male. He had no real large significant past medical history. He had some IBS. He had an unstable TMJ and some issues with that, and he had had a repair of an inguinal hernia with an undescended testes from when he was a young child. Apart from that, fit and healthy. He was a full-time worker in a call centre, and he was a paramedic student. He had had 3 prior vaccinations with the Pfizer vaccine before his infection. So he was infected with COVID-19 in April of 2022, confirmed on PCR. His acute symptoms weren't very significant. He didn't actually even have a fever. He did have some mild shortness of breath, a little bit of chest pain and some nausea, and he noticed a reduced appetite. That was virtually all he had in those first 5 days of his infection. He denied that he had any symptoms of syncope or dizziness at that time. And then he developed about 12 days after his infection some new symptoms, and they were, he noticed a new onset of headache when standing, dizziness and palpitations, which were also more associated with standing, and he had an orthostatic tachycardia. He developed quite severe refractory constipation with abdominal pain and loss of appetite. He also had intermittent diarrhea. He noticed thermoregulatory dysfunction, and he also had a severe brain fog, which worsened when he was sitting up or standing up when he could stand up. His fatigue levels increased. Those symptoms persisted for several months. He sought multiple assistance from multiple areas. He obviously presented to his GP, who was at a loss for the symptoms. He was presented to emergency 3 times. At least one of those was in an ambulance with tachycardia and chest pain. He was discharged on all occasions due to his negative ECG and blood. And he was given no further treatment, unfortunately, which led to him going home and becoming essentially bedbound. He was eventually referred to the long COVID clinic, but was unfortunately denied entry to that. And then fortunately, a second referral down to Flinders Medical Centre has resulted in him going to attend there, I believe, next week. But in the meantime, he declined so bad that he was unable to work. He never returned to work after his infection in April. He was unable to drive a car, could not actually walk apart from a few metres to the bathroom. He couldn't have a shower. He couldn't sit for more than a few minutes. So he came in to see us. He actually entered into our study and he came into the clinic. He was, you know, like all these patients, he looks relatively well. There was nothing startling about him. But on his Compass index score, we saw his orthostatic intolerance was a full 40 out of 40. His vasomotor was not a 5 out of 5, it was a 2.5 out of 5. He had his secretory motor, he had a loss of his sweat function and a very dry mouth. He had 12.5 out of 24, which was his GIT score. So his diarrhea was improving, but he had worsening constipation that was getting quite severe. He had no bladder symptoms at all, and that's actually not unusual. You see people that don't have that, and then you see people with terrible bladder symptoms. And he did have indicators of pupillary motor dysfunction, which we know seems to be associated with kind of more severe autonomic dysfunction. So there are things like light sensitivity and blurred vision, particularly in low light. So his total compass score was very high. That's a real red marker there for broad spread autonomic dysfunction. We do the fatigue severity score because it gives a good indicator of what people's fatigue is like. But the second marker on there, and this is his fatigue severity score, you can see is exercise brings on my fatigue. If they mark a high level on that, that's a good indicator that they're going to be pretty intolerant to any kind of graded exercise therapy. And until you manage their plasma expansion and their vasopressing, you're probably not going to be successful in sending them off for any exercise physiology. This is not him, but I can tell you on his standing test, he had severe acrocyanosis. So that's the dependent pooling of blood that is typical in these patients due to the loss of the vasomotor pressor system. We did, on all our patients coming into the study, we look at a 5-point hypermobility scale, which is called the HACM score. They self-report this, and he self-reported 0 out of 5 hypermobility, which is not unusual with males. They don't really think too much as children about their hypermobility. This is a reflective historical score. However, when we assessed him, he was actually very hypermobile. He had excessively hypermobile fingers. He also had hypermobile elbows and knees. He had very soft, extensible skin, and he had bilateral pysogenic papules of the heel, as well as atrophic scarring on his body with some perforation scars. He had dental crowding with a high narrow palate. He had a history of TMJ. He also had a mitral valve prolapse with mild regurgitation, which meant that he met the criteria along with his pain for hypermobile Ehlers-Danlos syndrome. His CT scan was normal, despite what you could see on his feet, and that's not unusual for our patients as well. His standing test, we do a beat-to-beat measurement where we can watch the blood pressure and the heart rate from beat to beat, which was helpful in this patient. Although he denied syncope, when we stood him up, he lasted 5 minutes before having a complete loss of blood pressure. However, he didn't have a bradycardia with that. He had the typical POTS reaction. Most POTS patients don't faint. They have a really good compensatory mechanism that keeps that high heart rate, but occasionally you get patients like this one who just have such little ability for preload to be returned to their heart that they lose their blood pressure. And he did that after the 3 minutes that is required for the diagnosis of orthostatic hypotension. So he met the criteria for POTS, but unfortunately had the unconscious collapse with post-vomiting. When we sat him up again, the same thing happened again. So we actually sent him off to hospital because at the time that we saw him, he was already optimised with salt and water loading because he was aware that he probably had POTS. He was commenced on mitogen, fludrocortisone and ivabradine and given IV fluids during his admission. I saw him at a 6-week clinic. He was sitting up, able to have a conversation with me over telehealth. He was now able to participate in small household duties. He was able to have a shower. And he was also driving short distances back and forward to the local shops. He was also able to do a small walk around the block. And he's now engaging in exercise physiology with our expert here who's really good at managing these patients and giving them some good biofeedback on how to manage their heart rates and look for triggers of crashes. He's also undertaking dietetics, which is really helpful for his GIT. Progressive, in terms of his progression now, he still has a lot of issues with orthostatic brain fog, which is not unusual in these patients because they have quite substantial hypoperfusion of their brain while they're upright, and he's still unable to work. His mental health is a lot better because he feels a lot more in control of his condition now that he knows what it is and he knows what he needs to do to manage it. He is looking to recontinue some of his study and his work. I just wanted to show you this graph because it shows that those with POTS and EDS tend to have a worsening of those GIT symptoms, and that's important in this particular case as well, because of the dysmotility that he's experiencing. This patient will need to go on with quite a bit of assistance in terms of that. Since we medicated him, this is his repeat GCSI. Originally it was over 2, which would have suggested gastroparesis, but that has dropped down, and that's not with treatment of his dysmotility, that's with treatment with fluids and vasopressing and plasma expansion. So just treating the orthostatic intolerance and the poor vascular perfusion and preload to the heart can actually help with the gut as well. Just before I finish, I just really want to make the note that children get PAS2, and this presents somewhat more subtly in some and quite overtly in others. I just got this email today, and I get, I reckon, probably 10 of these a week. And this is typical of what I see in young children and what we see here at the clinic. My daughter is suffering from unexplained seizures, weight loss, and no answers since she had COVID. The parents are usually at a wit's end about this. They're very concerned about it, and they often don't get much in the way of answers as to why this happens. Kids, and particularly girls who this mostly affects, tend to get quite substantial GIT dysfunction. When this happens, they can end up being admitted under the guise of sudden onset eating disorder, and it's often the case that they have a low appetite because of their GI dysmotility. So it's really important to look for that connection and to consider whether those patients actually have autonomic dysfunction. So the red flags for kids are increasing absenteeism from school, reduced academic performance, social withdrawal, reduced attention to detail, reduced athletic performances, and those increasing headaches and loss of appetite. So just to finish up, when you're doing your assessments, the things to look out for are those domains of orthostatic intolerance, vasomotor disturbances, secretory motor, GIT, dysmotility, bladder, and pupillary motor changes in patients. And a marker for referring them on out of your clinics is if you have managed them with lifestyle change advice and they still have refractory functional decline. If they have evidence of marked hypermobile EDS, so that may be, you know, quite significant joint dislocation, then they probably need an echocardiogram. If they have persistent cardiogenic symptoms such as those hyperadrenergic responses, so sometimes on the standing test we see these really high blood pressures as an oversympathetic response, or if they have frequent syncope, chest pain or arrhythmia, then despite management, then they're probably good to come for a referral just to make sure that there are no other markers, cardiogenic markers in there that we need to look at. And this is just a tool that we use from the POTS Foundation. It's the 10-minute standing test with a little bit of an algorithm for you to have a look at on when to refer. So I'll hand back over.
Brilliant. Thank you both so much. Are we, Dr. Lau, are you going to continue to speak more now? Okay, perfect.
A few slides. I think we've gone through the assessment, and this is just what we do for lifestyle management. Water, 3 liters a day, salt up to 10 to 12 grams, compression wear like 2XU that you can buy from the sports stores, and then some exercise will be helpful as well. And I'll tell patients to avoid triggers, standing still for a long time, heat, hot showers, and sometimes dietary management. So just a summary, as I mentioned earlier, that treatments are often not so efficacious. Sometimes we need combination treatment, and a lot of them are just more consensus-based rather than data from randomized control studies. There are currently, unfortunately, no TGA-approved pharmacotherapies for POTS, and this is also largely due to what we've been using so far in the ICD code, ICD-10 version, where POTS is not even has got a code in there, and that makes it harder. And we use a lot of medications as private scripts, which is of non-PBS. So just to sort of highlight this, to say that we talk about classifying them as to which type. If you suspect the blood volume is low, for example, people with shutdown peripheries with a narrow pulse pressure, salt and water will be more of a higher yield, and also adding in fluorocortisone early. For people who have a lot of dependent acrocyanosis, then that is due to venous pooling. Compression garments will give you a higher success rate, and also things like midodrine with vasoconstrictive effect will be useful. In tachycardia, which often is a strong feature, then we use a beta blocker such as propranolol or ivabradine. I myself use ivabradine more, as a lot of these patients will eventually manifest with low blood pressure. So ivabradine doesn't decrease your blood pressure, will be gentler to them, and has been shown, at least in our hands, to be quite effective. And then if they have gastric symptoms, then sometimes dietitian and a trial of different diet will be useful. In a lot of patients, after one agent, we often might add on a second or a third. And also in refractory cases, which is a small percentage of patients, we give them IV fluids. So I won't spend much time talking about that as we're running out of time. And just to highlight here, this is a complex condition, and often, the GP is at the center of all this care, and will involve different specialties as required based on the symptoms that are presented in the patients. So thankfully, a lot of patients will improve, although curing them is going to be a lower percentage. These are just 2 series that are published in the literature, and that the first one is 60% of adolescent patients that are treated and follow up at 20 months. Majority have significant improvement, but still up to 10-12% were highly symptomatic, and a large portion was still on medications somewhere around 2 years later. The second one is the survey of 5-year study, where only less than 20% reported recovery. This is survey-based, and majority still has significant disability. So just concluding here, this is a huge challenge for us with more patients with this problem, and a lot of them were significantly affected, as Claire has highlighted in her case studies. And there's a lot of cost in treating them, as the medications are not the PBS, and we need to urgently upskill everybody to be confident to deal with this. And obviously, funding will be helpful. So I'll finish there, Eve, and let you take over, and we'll be happy to answer some questions.
Brilliant. Thank you both so kindly. And so it was Professor Dennis Lau and Marie-Claire Seeley. That was really, really interesting. And I think you really pitched it great at those office-based tests that GPs can adapt for their setting. So the Q&A box is there, the chat function is there. Please jump on and pop your questions in. I was just going to ask one question. Just Marie-Claire, could you explain you had pseudo scan written there? Could you just explain what that is for us?
Yeah, I should have gone through that. Sorry. So we look at, it's very difficult to directly test the autonomic nervous system. We can't, do nerve function tests very well for that, like we can for the central nervous system. The pseudomotor function, so your sweat function, is controlled by the autonomic nervous system. So looking at sweat function, the typical tests for that are the QSAT or the pseudoscan. Both are used relatively infrequently in Australia, and I don't even believe there's any Medicare rebate for either of them. However, on pseudoscan is a test that is used for diabetic neuropathies to determine progression of autonomic dysfunction, and particularly of the small nerve fibre dysfunction. So somebody with a low pseudoscan, it's essentially a test that looks at the sweating function of both hands and feet, and that can tell us that there's some dysfunction in the small nerve fibres. It's not really clear to us that that is linked to reduced functionality. So you can see normal controls with reduced pseudomotor function, and they're typically people that might get Raynaud type phenomenon and so on. But it is helpful in the context of of COVID and POTS to at least look at it in conjunction with their other symptoms.
Yeah, fantastic. We've had another question come through. Are GPs able to refer patients directly to your service? Dennis, did you want to field that one?
Yeah, look, our service, we've been running this for a while, and the problem now is a long waiting time. We have added another colleague to help up with the nursing assessment, but the waiting time is into the new year, quite some months away. So I think, yes, we're happy to see them. And I think the key message tonight is to give you the knowledge and hopefully the confidence to start recognizing these patients, do some assessments of them as they come to see you at different visits. You can't do all of that in one go unless you already planned a long appointment. And then once you have the data or the results of the standing test, I think the lifestyle treatment option, give them a week or two, get them to come back. If the standing test is negative, but you're suspicious of this, then you still would give them the lifestyle management advice, and then maybe get them to go home and do the standing test at home, because it's not a complex test from lying to standing, and that gives you more data to look at and see where the problem is. And if they come back with significant tachycardia, after still on lots of fluid, salt, and all that, then you can start them on ivermectin. It is just a standard private script, and then always start low. But if they don't find it useful, doesn't mean that the tablet doesn't work, but you have to crank up the dose. I use up to 20 milligrams in total a day, so it comes in 5 to 7.5 milligrams. I give it twice a day because it's a usual BD dosing. And I don't want the resting heart rate to be too low. So I'll give them first dose in the morning when they wake up, and second dose often 4 to 6 hours after, so that we cover the awake hours when they are doing things, they are standing, so that will help with the tachycardia. If you then see low blood pressure, then you can start Florinec, which is on the PBS, 0.1 milligram dose. You will do that first dose in the morning, and I hardly go over twice a day. So the second dose at lunchtime, so 0.1 and 0.1, because if you take it too late in the day, it may affect their sleep. So you do that earlier part of the day, and if they're still having low blood pressure, then you add in the expensive migraine, which is 90 tablets for around $150 to $120 a box of 90 tablets. And then I will use up to 30 milligrams a day. And that is something that I give in divided doses. So they last only 3 hours per dose. So TDS, QID, 5 to 10 milligrams each time, to a maximum of 30 in general. So if you still find that they have a lot of issues, then hopefully by then we will be up to the queue and we can see them. But I hope a lot of these patients have milder form of this condition can get a lot better with your involvement, so that they don't need to be seen in the long COVID clinic or to come to see us, because it's not possible that if there's 200,000 patients in the whole country, there will be 30,000 in South Australia. So it's not possible that we can cope. But hopefully you guys can play an important role in combating this problem.
Thanks so much. We had another question here about patients who are already on beta blockers. So is it possible to diagnose POTS or post-COVID if the patient is on beta blockers?
Definitely more challenging. And sometimes we, to clarify the situation, we will wean them off it and do a standing test without it to satisfy ourselves. But we will take the diagnosis not just based on standing tests alone. The whole dysautonomia is a multi-system problem. If they have a lot of other symptoms, we will recognize it from a long distance, and instead of taking them off, making them feel lousy, confirming on the test, we will often, if they have low blood pressure and they have the side effects of beta blockers, like lethargy, depression, sleepiness, and low blood pressure, we will swap them to ivermectin, which I think in our experience is far more effective than beta blockers.
Brilliant. Thank you both for sharing your expertise. Just check one more question there. Are there any gastroenterologists with an interest in POTS related GI effects?
There's not really anyone specifically, definitely not anyone specifically, but we certainly have gastroenterologists who have seen a lot of our patients. The difficulty with the GIT dysfunction in this disorder is that there's no real solution to it apart from frequent trials of prokinetic medication, so working the way through that. If they have significant weight loss, then that's a good indicator for GIT involvement or gastro involvement. Particularly, some of the patients can develop the SIBO because of the stationary bowel that they get. And if that gets to a high level and they've got diarrhea and weight loss, they need some involvement. But it's a difficult area all around the world at the moment because there was very little known about the autonomic function of the bowel, and most gastroenterologists are looking for more organic causes. Yeah,
I mean, that's exactly the scenario. We, I think after a normal endoscopy, they will try not to see the patient in the long term, so you end up back in our clinic, and it's not so easy. Some dietary strategies being proposed overseas with still not very strong data to date, but I think hopefully we'll find someone interested in South Australia who could help us down the track.
What I would probably say on it though is that one thing we know helps them is the smaller meals and avoiding foods that do bloat, because if their small bowel is quite stationary, they tend to do better on the FODMAP diets and those things that are not going to ferment and so on. So that's a really good place to start with them, and referring them to a dietitian can probably be a better result, I think, in terms of management.
Well, thank you both so much. We so appreciate it. You're welcome to stick around in case we get any more questions. But of course, I'd invite any GPs to send any questions in via our GP liaison email, and we can forward them on to these experts in the topic and get back to you with some more information. So I'm going to move on to our next part of our talk now, and I'll just share this one. So hopefully that's all working there, and you can all see my screen. Any luck there? Nope. Nope, no luck. Hold on. How's that? Let's try this. Okay, we're in business. Thanks for hanging in there with me. Okay, so we're now coming to the end of our 2 lots of webinars. We've heard from Dr. Kasani, rehab physician. We've heard from the Adelaide Health team at the Long COVID Clinic. We've heard from Dr. Lau and Marie-Claire tonight, and it's really about how do we wrap all that up and go, okay, well, someone's sitting in your consult room, and what do we actually do now? And so where do we really start? So that's what these few slides, and we'll whip through it because I know it's getting late on into the night. So first of all, you've seen the timeline, you've seen the definition. That's not anything new. But I just want to really highlight that we're talking about anyone from 4 weeks. That's when we can start investigating and assessing these patients. We don't have to wait till 12 weeks to begin that assessment time. And another reminder as well that all these slides and recording of tonight's webinar will be available afterwards. And for this part of the talk, I'm really going to be focused on adults, so just highlighted down the bottom there. And this definition, like the others provided, fits with the WHO definition that came out about a year ago now. So from the GP perspective, if we've got someone that is come in with concerns about ongoing symptoms after COVID, this is really the goal of assessment. So we want to check if they've got those red flag symptoms that would require emergency assessment. We want to see if they've got any specific complications from their COVID-19 infection, and we're going to explore this tonight. We want to see if they've got long COVID, as in persisting symptoms for more than 3 months that don't have an alternative explanation. Assess whether they are actually got symptoms because of their acute COVID was so severe, as in post-intensive care syndrome or other, and see whether some of their symptoms could be related to a chronic comorbidity that's been exacerbated. So that's the goal. So we want to check red flags, we want to see about complications, see if it's long COVID, was it post-intensive care syndrome, and is it an exacerbation of their other illness. So when we come to assessment, the key principles here is really taking the time to listen to our patient, which we all do wonderfully. I know everyone here that's turning up that would be interested in tonight would absolutely do this already. But just to really highlight that that's the feedback from the UK patient experience as well, is just to listen to the patient, take the time, validate their experience. I won't go through all of the symptoms that we can get, but I'll refer you to this flow chart down here. So this is the National Clinical Evidence Task Force that lists out all the possible symptoms. And in that flow chart, we have these red flags. So, and I've just added here, even though we're not focused on children, but PIMS-TS is one of those for children as well. Also in your history, you want to just check about the details of their acute COVID infection and check about their function. So that could be their employment, education, how much they're caring for family members, and how does that compare pre versus post COVID to how they're doing now. Another key thing that we had learned last week was always asking about that post-exertional malaise. So that is that crash, so absolute worsening of their symptoms and condition, either immediately or up to 72 hours after an activity. And that could be both physical activity and cognitive activity. So really important to just check on that. Run through your systems review, check on their comorbidities and their current level of those, and think about symptom assessment tools. Examination, so everyone will be doing this already, but really you're targeted to the symptoms that patients come in said, and the other key ones would be thinking about vitals, so oxygen saturations, temperature, weight, and as we just had a good presentation on that, lying and standing blood pressure. The 1 minute sit to stand is really good to be checking for that oxygen desaturation with more than 3% drop being significant. And the further postural testing, like doing the 10-minute NASA lean test that we already spoke about tonight. There's so many assessment tools. Where do you start? Is a little bit difficult. For me, I would be picking out one of these top two, a really great place to start. So at the first consult, I'd be printing these out, sending them home with the patient to fill in. And the reason this is a good place to start is because these can be repeated over time, and that can be used for patients to reflect on their journey through their recovery. The C19YRS is validated, developed in the UK. It takes about 15 minutes to complete. It's about 15 questions. And like I said, I would print it out and send it home with the patient. The other ones are a little going to be targeted to the patient's symptoms, and we heard a lot about the Compass 31 just before, and then picking your other symptom scales depending on the patient's symptoms. I won't go more into the Compass 31 because we already heard a lot about that. That's just what the C19YRS looks like and printable. So you might then, so that first appointment, checked all those red flags, gone through the history, decided to hand out the C19YRS or send them home with some symptom tools to complete, and we're deciding about some investigations. So there's no test to tell us this person has long COVID yet. And the aim of organising investigations is to target the patient's symptoms and detect those complications that we're talking about. So this is obviously quite detailed and just not an exhaustive list though. So it's really using your clinical judgment and assessing the situation. And I'll let you sort of have a look through that at your leisure. A good one, I think, here to keep in mind is the risk of clots, PEs, and so this is a really handy flowchart assessment from the New South Wales Clinical Practice Guide, and the link will be here in this website. So going through your D-dimer and then what next. So just keep in mind that it definitely is on our list of complications. So let's cover those complications and just go through what are we seeing post-COVID, what is more common, and what do we keep an eye out for. So lots of pulmonary fibrosis, increased rates of impaired lung function detecting, clots, increased rates of ischemic heart disease, MIs, myocarditis, arrhythmias, strokes, both ischemic and hemorrhagic being seen, heart failure. And this is not super informative, just listing them out, but it's really just to keep them in your mind and go, okay, well, this person's had COVID. These could be more common. The European Academy of Neurology, it just in June sort of gave an estimate of ischemic strokes being 2.7 times more common, and the hemorrhagic strokes being 4.8 times more common after COVID-19 when they compared two cohorts of COVID-19 positive cases and their recovery versus controls. Lots of neurological conditions, so we've covered stroke, encephalopathy, myelitis, and it's this post-COVID-19 neurological sequelae, which is really we can't label it as anything else, but there's definitely a neurological impact after COVID, and some correlation being seen between neurodegenerative disorders and COVID-19. In addition, this really interesting study from the UK showed that it's not just the people with the moderate severe being in ICU with their COVID-19 infections, but it's even the mild COVID-19 infections that are showing grey matter loss. So they took nearly 800 people and 400 of them had COVID, and they did MRI scans before and after their COVID-19 cases, and they demonstrated all these highlighted areas of where the grey matter loss was shown. So just something to keep in the back of our minds, sorry for the pun, about the long-term impact of COVID going on. And in addition, not just those areas that they saw highlighted there, but a greater reduction in global brain size was seen as well. We've also got the mental health effects, and I think this was a really interesting. They used the US Veterans Affairs database, and they showed that at 1 year post-COVID-19, all of these rates of diagnoses and even scripts for antidepressants, opioids, and diagnosis of sleep disorders, depression, stress adjustment disorder were all increased in the COVID-19 group versus the control group. So those are seen to be more prominent, so keep those on your list there. And to wrap up the list of complications, we've seen, impaired diabetic control, new onset, both type 1 and type 2 diabetes, subacute thyroiditis, new onset hypothyroidism, mast cell activation syndrome, a whole range of complications going on there. So when we wrap that all back up into where does that leave us when we're sitting in the GP room with our patients? So we've really assessed these people that have come in with their symptoms. We've done a thorough assessment. We've checked for those red flags, listened to our patients. We've checked off their comorbidities and made sure that they're managed as best they can be. Arranged some of those investigations to check on their symptoms. Thought about those complications, whether we could detect any of those, and we've said, right, well, we think this probably is long COVID, so this is the diagnosis at this point. It's just really important to be aware that patients could have belong to more than one of these cohorts at once, and that there still might be non-COVID related illnesses that go on here as well. So at that point, once we've finished this assessment, if you did find one of those complications, you would manage that appropriately and follow those pathways. If we thought it was exacerbation of the pre-existing disease, that again, we would manage that just as we would do every day and refer back to the treating specialist if we needed that. And we're going to focus on these two middle cohorts here and look at what we're going to do next for these people. And really the next steps of management is about how severe their symptoms are and how functionally impaired they are to decide what to do next. So this is these two cohorts we're going to think about here, and this is really going to be depending on, again, how severe their symptoms are, how functionally impaired they are day to day. So in line with sort of the national approach and what other jurisdictions are hoping to do and what the UK are doing, and knowing our capacity as GPs and what we can offer our patients, hopefully majority of these patients will be able to remain in the community with supported self-management, with our guidance and our care, maybe some community allied health input, And then some patients who maybe have very severe symptoms, severely impacted, their diagnostic dilemmas, maybe they need lots of different allied health inputs, so they need that multidisciplinary aspect of the tertiary clinic, or they had really severe initial infection. Those are sort of the patients we'd be thinking, right, yep, let's organise a referral. And perhaps those other patients, we could try the supported self-management and community allied health and our GP management as best as we can first. I think really interesting to hit home this point is that in the UK, their sort of data from September up till September showed that of the 1.8 million people they had affected in the UK, more than 500,000 of those had symptoms for more than 2 years. So that's an extremely long duration, and it just shows the central role that GPs and we need to use our longitudinal relationships with our patients to support them through that recovery. I'll just highlight here that you might be thinking, oh, well, this is a little bit in contrast to the webinar we had last week, and we went through the referral criteria with Dr. Kasani. This is, just to be really transparent, this doesn't match up exactly with the exact referral criteria you'll see on the referral PDFs for Flinders or the Royal Adelaide, but this is just a vision of how we think long COVID can be and should be managed. So what can we offer our patients in GP? So really there's no cure for long COVID, as you would all know, but it's symptom-based management at this point. So first of all, we can really support our patients. We can print off either of these two great resources, and that's what the long COVID clinics are providing patients when they attend the clinic. Symptom diaries and tracking is a really great thing to suggest. So that's coming back to the idea of using these tools and checking in monthly, getting scores and tracking the patient's progress. Jack last webinar linked a really good fatigue diary in that we could suggest to our patients. And we want to take that energy conservation approach, which is the pacing, prioritization, and planning. And again, no recommendation of exercise if we've got the post-exertion symptom exacerbation. So just being really cautious about that. And this resource here, I'll just bring it up here to show you. So it's about a 4-page resource, and it goes through all these different ideas like laundry, cooking, shopping, and just different ways patients could break down the task to manage it. So it's really great resource to hand out and really useful. There's more we can still offer our patients. So we could suggest they find some support groups. So these are just some ideas. There's a load of Facebook groups, very active on Twitter. Long haulers is the name that these patients originally gave themselves from the US. The Long COVID Sessions podcast is terrific. It's run by 2 patients in the UK affected by long COVID as they interview different medical specialists about the reason why and their research. So it's really interesting. We just heard a whole lecture on POTS and the great things like, we as GPs can pick up on that. That's tests we can do in our office, and there's lifestyle advice we can instigate. There is a really good quick 1-page GP guide on POTS UK. So very quick summary of where to start with that. And the best part about GP is we can get our patients back again. So remember, just be mindful to maybe separate the appointments out for our really fatigued patients. We have that beauty of follow-up. Think about investigating if there's new symptoms. Regarding vaccination, there's a study out of the UK showing it was about 200 something patients, and it showed that for majority of long COVID patients, their symptoms got better at the 1-month mark. But for a minority, about 8% of that cohort, their symptoms got worse after vaccination. So I think just be mindful to still promote vaccination, but just be upfront about that small risk of worsening, but majority got benefit in that study from the UK. Reaching out to our allied health colleagues, thinking about a long-term plan coordination by setting up GP management plan, using case conference item numbers, and just being really cautious when we suggest a mental health care plan that this is perhaps about how to cope with the symptom burden, not necessarily for a primary psychological illness newly diagnosed. Like, fair enough if that is a diagnosis its own, but just be cautious in how we approach that. And we're here to walk the journey and just share the uncertainty with our patients. So these are some great resources to look at. So on Health Pathways, we've had an adapted page for South Australia. So that's the login and password to log in there, and you just look up post COVID-19 and you'll find that there. The National Evidence Task Force is a 2-page flowchart, which is terrific. The New South Wales Living Evidence Guide is being continually updated, and so it's updated sort of every month or so in line with new evidence. And then, so for those patients that we do actually think, well, right, the supported self-management, we tried that, we haven't got anywhere, or they fall into that very severe category straight up. These are our referral options. So we've got the Long COVID Assessment Clinic through the Royal Adelaide, and that's sort of how their referral form looks there. The main things that you would expect is they want details of the PCR, the RAP, make sure there's no red flags. All patients require blood and urine tests within the last 2 months, and then some targeted investigations depending on the patient's symptoms. We heard about the CALHN Flinders the post-COVID-19 clinic last week, and you can find it under the rehab clinics tab and under here on referrals. Very similar criteria, but includes some exclusion criteria like risk of suicide and suspected VTE and things like that. There's no formal long COVID clinic at NALHN at this stage. And for children, you can do a referral to General Paediatrics Outpatient Department. So just want to wrap up by just touching on the lived experience. So this was a UK respiratory physician, he's very prominent on Twitter, who's actually been affected by long COVID. And he said, and you see the quote there on the screen, the jump from normal tests to this must be psychological. We have to stop that. Just because your usual battery of tests is negative does not mean you can automatically diagnose someone with a psychological illness. People can be very sick with normal tests. It just means you have to keep looking harder and believe your patients. And I think there are abnormalities being shown. There's heaps of research showing that. So this is, you might have heard about microclots. So this is some of the evidence from Dr. Pretorius in South Africa on presence of microclots. This is on plasma proteomics. There's loads of research out there. It's just that we can't order these tests down the road at ClinPath or SA Pathology. So it's coming. Hopefully this space we'll see more in it in the future. So take home messages, listen to our patients. GPs, we have so much to offer our patients, even though we all don't understand enough about long COVID yet, and look out for those complications. All right, so that wraps up. Do we have any other final questions? I just checked. Yeah, we've still got Dennis online. So we've got a question here. We were told the peak onset is in the 14-year-old. In what way will management differ? So just check. Not sure.
Okay, can you hear me?
Yes, we can.
Okay. So yes, we do see a lot of teenagers come into our clinic. The youngest we've seen is 6 or 7 years old. So this is the age that they start to present. We're talking about POTS in the absence of long COVID. I'm sure we still get the long COVID teenagers that we see. In what way will management differ? I think we would always defer medication therapy if we can help it, given that they are young, by using as much lifestyle management options as possible. But if they remain symptomatic and we don't have a choice, then it's using the same medications, but obviously at a dosage according to the body weight of the patient, and then start low and gradually up titrate as required. So there is, in other words, not a lot of difference.
Terrific. Thank you so much. that is all the questions. So I just want to say really big thank you to Adelaide PHN for hosting tonight. Big thank you to Professor Lau, Marie Claire as well for your great presentations and really interesting research and very applicable for GPs. And thank you to everyone who has joined us tonight to tune in. So we'll leave it there, and the webinar and recording will be available, and we'll make the slides available as well. So thank you everyone so much.